right? Okay. So the bottom line is that there are two eligibility criteria in the regs. Terminal illness with a life expectancy of 6 months or less if it runs its expected course as deemed by the medical director with support from the attending physician, if available. And number 2, the patient elects the benefit. Patient or the patient's representative elects the benefit. Most hospices interpret the word representative as meaning family. The cops actually don't use the word family. They use the word representative. It's unfortunate that they don't use the word surrogate. So no one knows what representative is. And depending on where you are around the country and whether or not there are ethics reviews and that sort of thing, some programs will allow patients without families to access the benefit. Most will not, though. Okay. How does hospice work in terms of the processes of care?
Just one issue kind of coming across very often. For example, there's a patient I see and is kind of in dying phase due to terminal illness, comes to our unit and there's no family, no surrogate. Can you make this patient hospice patient?
Right. So the answer to that is no, unless you have a policy and a procedure that has been vetted by the organization. And actually, the safest way to have this is a policy that's been approved by the Hospice Board of Trustees, Board of Directors. We, in our prior hospice, continuum hospice care, we had a policy that was approved by the Ethics Committee, provided a procedure for bringing people in. It involved a due diligence search for the family, a review by an ethics subcommittee, and that policy was approved by the board, and we implemented it. We will have that going forward, but right now we do not have that yet in our current hospice program. So the answer is no, we shouldn't put those people on the hospice. Okay. How do the benefit periods work? Suppose the patient has a lung cancer metastatic to bone, and the patient has been getting a platinum-based chemotherapy and paclitaxel and a biological agent, and the disease progressed through that. And now the patient has opted not to get any more chemo, understands that the next chemo has a 10% chance of a partial response. There were a lot of side effects with the first group of chemos, and the patient says, I don't want any more chemo. So the patient is now set, but the patient does have a painful bony lesion. The patient wants radiation. Is that patient eligible for hospice? So that patient is eligible for hospice. Could the hospice program provide the radiation under the law? Yes. But if the hospice program provided the radiation, the hospice program would be responsible for paying for the radiation. And many hospice programs, including our own, would say, well, the way the healthcare system is set up, get your radiation under existing Part A benefit or Part B, and then we'll take you into our Part A benefit. That's because once a person elects the hospice, it is capitated, full risk, right? Which is different than the fee-for-service model than the rest of Medicare. So if you think about it, there's a fairness issue. I have no problem with hospice programs doing a financial analysis as part of the care process because they need to survive to provide care. If they don't survive, there's a justice issue. You can bankrupt all the hospices of less than 100 people in the United States. You'll go from a current 4,600 hospices down to probably less than half that. You'll provide reduced access, and so that's not right. So hospices do have to do a financial analysis. And in our hospice here, even though we have a large hospice program, our analysis would be Medicare has set up a fee-for-service system upstream from hospice, a full risk capitation system for hospice benefit. The radiation is going to take you 10 days. So get your radiation first, and then we'll take you. I personally, you might have a problem with that. I can understand that. It's something to be discussed, but I don't have a problem with that. The moral principle, the ethics of that really relate to justice, distribution of healthcare resources. Because if we provide radiation to everybody who's sick, we'll be bankrupt. We'll have to go out of business. So that kind of patient would be eligible for hospice. And how does the hospice benefit periods work? The patient has to sign an EOB, and the physician, the medical director, and the attending has to sign a CTI, certification of terminal illness. Right? And so until the certification of terminal illness and the EOB is signed, when the EOB is signed, the patient has elected the benefit. Until the CTI is signed, the hospice cannot bill. But the EOB is not legal until there's verbal certification, so it requires verbal certification for the EOB to be activated, but the hospice can't bill until there's actually a written CTI. So the patient will sign on, and do you know how the benefit periods work?
Certification and recertification?
Mm-hmm. So there's
the first one is 90, and then every 60.
No, 2 90s and then it's every 60. So there's two 90-day benefits, and then an unlimited number of 60-day benefits. Each benefit period after the first requires recertification by an employed physician, by a hospice medical director or a designee. Right? Each one. And beginning in February 2011, within 30 days of each benefit period, at 180 days and 60 days every period thereafter, within 30 days of each of those milestones, the patient will need to be seen either by a physician or an NP in a face-to-face encounter, and there will need to be written documentation justifying the continued eligibility. That's a big change that was put into effect by the government to try to reduce fraud, abuse, and misuse of the benefit.
Do the 60-day recertifications have to be done only by physicians, or does it say a designee, or does it have to be...
The signing of the CTI must be done by a physician. The face-to-face visit within 30 days of the milestone can be done either by a physician or an NP. Okay? And if the MP does it, the MP is doing it in the stead of an attending physician, of a medical director, of a physician, and he or she has to discuss the case, and then the physician has to write a narrative and sign the CTI. All of the CTIs now in the United States have a narrative. That's another change to try to reduce fraud and abuse. So every certification has to have a written narrative justifying eligibility. And every certification from 180 days through infinity now requires a face-to-face encounter. Now that's a huge change in hospices, because you can imagine that small hospices in rural areas that service these huge areas, and they employ physicians very part-time. Now they suddenly have to get physicians on a per diem basis, or they have to increase their employment of these physicians in order to get them out, or NPs in order to get them out into the community. One of the huge quality issues of hospice, one of the reasons that mainstream doctors like myself took a long time, or are taking a long time to recognize how vibrant and important the benefit is because historically, hospice programs would employ physicians for really minimal amounts of time, 2, 4, 6 hours per week. All the physician input would be from the community-based physicians who knew nothing about palliative care. The employed physician designated as the HMD himself or herself would have no requirements for credentials in palliative care. So you had the blind leading the blind on the medical side. You would have incredibly skilled nursing, potentially, not always, with very little quality assurance and quality improvement activity in hospice programs. So there was no effort to ensure that the nursing was high quality, the social work was high quality, pastoral care was high quality, none of that.